Good morning in England, good afternoon in India. How is prostate cancer detected? The majority of these patients are found by case finding, and these are patients that go to see their general practitioner and then referred on to the urologist, and they present with a wide variety of symptoms, most of which have got absolutely nothing to do whatsoever with prostate cancer. They come with lower urinary tract symptoms, they come with UTIs, hematuria, erectile dysfunction, and most of all in this millennium, patients come with anxiety and they're anxious about having cancer, and a lot of them are very educated and very unwell. Sorry, the word well.
Okay, fine. Yeah.
Sorry. So, sorry, was I on the wrong screen?
Yeah.
So just single click on your slide, it will change.
Okay, I got it. So we would term this early detection of prostate cancer by finding these cases, which is a form of screening, but which is very different from population-based screening, which I'm going to come to in a minute. So what do we do with these patients when we see them? I don't know whether you've ever had the opportunity to see this or not. This is a painting of the Sistine Chapel of the ceiling in Rome, and it's by Michelangelo, and it's in the early 1500s. And some say that this image here is a depiction of God. I'm not sure. I think it looks to me like a consultant urologist in his consulting room surrounded by staff. And if you look at his right hand and his arm, he's ready for a digital rectal examination. Now, digital rectal examination belongs to centuries old. And I would like to put it to you that it hasn't lost its value. Some registrars recently said to me, well, why do a DRE when you've got a multiparametric MRI scan? The multiparametric MRI scan is increasingly important and is extremely important. But I put it to you that you shouldn't think about treating a patient or operating on them without assessing that patient. So it gives you an idea to assess the size and the consistency and a very inaccurate stage of that cancer, but it's still extremely important. In addition to that, you need to see the whole patient. You need to see their build, their nutritional status, whether they're thin, fat, obese, their fitness for surgery, their physical performance, assess their comorbidities. You need to assess whether they've had previous surgery or not, and also things like hernias. What you don't want to do is to find this out in the operating theatre for the very first time. So please do continue to examine your patients. Next, the next in our armory of diagnostic tests is PSA. And what is the value of PSA? It's often questioned. It's a poor marker, but it's probably the best marker we have at the moment. Bill Catalona from Northwestern University in Chicago did some research in the 1990s. And if you look at patients with a PSA between 4 and 10, 26% of those patients have prostate cancer. And if you look at those patients with a PSA above 10, then 53% of them have prostate cancer. And of course, all of these prostate cancers mean different things to different people. But if you look at a so-called normal PSA, look at this, for example, a PSA between 3 and 4, there's still a 26% chance of finding prostate cancer. If you go to what we would consider to be a completely normal PSA of 0.6 or 1.0, one which would normally be very reassuring, then still 10% of these men have got prostate cancer. So what else do we need to look at? Well, one aspect, for example, is PSA density. That's the amount of PSA per milliliter volume of prostate gland. Those patients with a PSA of more than 0.15 nanograms of milliliter prostate gland are more likely to be diagnosed with prostate cancer. Also, PSA velocity. You have to be very wary. The PSA can shoot up with retention, with UTIs, and for various reasons. But if that PSA is increasing year on year by more than 0.75 nanograms per milliliter per year, then there is also an associated increased risk of prostate cancer. Now, what about other aspects? We can look at things, for example, ethnicity. African American men are much more likely, of a much greater chance of developing prostate cancer over their lifetime. Family history of prostate cancer, patients with BRCA2 genes also have an increased risk of prostate cancer. What other factors have we got to help us? Well, there are various biomarkers, PCA3, 4K score, prostate health index, HK2, and there are prostate cancer risk calculators. Some of these come and they go and they wax and they wane, and they're of variable value. None of them have found mainstream acceptance in NHS practice in the UK. So what is needed? I would put to you what is really needed, what is desperately needed in medicine and in urology is that magic bullet to differentiate between the low-risk indolent tumours and those aggressive tumours from which men may come to harm, and that is what we need. What do we do after our PSA test and our digital rectal examination? In 2020, the in thing is to do the multiparametric MRI scan followed by a transrectal ultrasound scan or perineal biopsy of the prostate. I'm going to keep that very brief there because I have other colleagues who are going to speak on those issues later. Population-based screening, that's different from screening in your consulting room. That is to take all of the men in a given country and screen all of them. And there are a number of criteria which were published many years ago as to what is important for population-based screening. And prostate cancer does meet a number of those criteria, but by no means all of them. And one of the important thing again is this spectre of the indolent tumour. We do not want to find indolent tumours. We don't want to find tumours that men can live to be 100 with and are going to die of old age. Because if we treat those men, that's going to cause them significant harm, and we're going to do more harm than good. So to screen or not to screen, and this is talking about population-based screening, it's very controversial. Several trials are being conducted in the States, and no significant difference in prostate cancer mortality has been found between screened and unscreened populations. One European trial, I was lucky enough to work in Rotterdam some years ago, and the ERSPC was centred in Rotterdam, has found some benefit, but it's very limited. So overall, what are the negatives from population screening? Well, there are false negatives. There are also, of course, false positives, finding men with raised PSA who don't have prostate cancer, and again, this issue of finding men with indolent tumours that don't need to be found. And then there's the pain, bleeding, infection and sepsis from the ultrasound scan and biopsies, overdiagnosis of indolent tumours, and the anxiety caused by screening. So what's the current situation on population screening? In the UK and Europe, it's definitely not recommended. The UK recommends a policy of early detection through case finding, which is what we do when we're in our clinics. And more importantly, NICE, the National Institute of Clinical Excellence, which advises doctors and the NHS in England, recommends that we give balanced information about PSA testing and treatment before going on to do a test. We're all guilty of seeing a man in a very, very busy clinic and just doing a PSA test. I'm just as guilty as anybody else, but we need to be wary. We're not doing all of these men a service. In the United States, in 2012, the task force there came down with a very heavy recommendation against screening. There was a lot of pushback from American urologists and the AUA, a lot of powerful lobbying, and also, incidentally, prostate cancer mortality went up after 2012, and therefore they modified this advice. In 2017, they've advised that men between the ages of 55 to 69 should have a discussion with their urologist, have an appropriate informed decision-making before going on to be screened. They also stated that men under the age of 55 who are in the high-risk categories, and I've just alluded to those earlier, African-American men, BRCA2 gene, strong family history of prostate cancer, they should be considered for screening in the urologist clinic. So treatment, who are we going to treat? When are we going to treat? And what are we going to treat? Risk stratification for men with prostate cancer. This has some bearing because the low-risk tumours carry a very low lifetime risk of developing metastatic disease and progressive disease. So what is the latest categorization? Low risk is a PSA of less than 10, a Gleason score of 6, and either an impalpable tumor or a tumor that's limited to 1/2 of one lobe of the prostate gland. Intermediate risk between 10 and 20 PSA, Gleason score 7, or tumor involving no more than 1/2 of one lobe. High risk tumors more than 20, Gleason 8, 9, or 10, or a tumor involving both lobes of the prostate or extending outside of the prostate. So what's an overview of the treatment options? I'm going to be very superficial with this because other people are going to speak about individual treatment options. Watchful waiting and active surveillance, there's a large difference between the two. Watchful waiting may be suitable for older men with a very limited life expectancy, and those men will only be treated if they develop symptoms. Active surveillance, it sounds similar, but it's actually very different. It's an aggressive manner of following up patients and monitoring patients with regular testing. And the goal of that is to institute treatment before a man can come to harm and whilst he's still in a curative state. Radical prostatectomy, radical radiotherapy in its many guises, cryotherapy and HIFU I put in between brackets because these are not mainstream treatments. They have some inroads in the UK in some of the bigger units that are carrying out randomized trials, and currently NICE only recommends cryotherapy or HIFU if given in the context of a clinical trial. So this is a very busy slide. I'm not going to go through it all, but and this is in actual fact taken from old NICE guidance. What are the options for treatment by risk category? You can see here, even with watchful waiting, high-risk patients, if patients are old enough and frail enough, could even have the option of watchful waiting and then wait till they develop symptoms. Again, I won't go through the whole of that. So what is the evidence for treatment? Why do we treat people at all? Bearing in mind some of these indolent tumours. 3 randomized controlled trials, the Scandinavian trial, which is now somewhat dated, but keeps getting updated every few years. It's a trial which looks at surgery versus watchful waiting, and look at that definition. Watchful waiting is not the same as the modern active surveillance. There was a small advantage in terms of prostate cancer and overall survival in treated patients. The PIVOT trial is a Veterans Administration trial from the States. That, again, showed only very small benefits, and particularly for those men with intermediate risk tumours, not with low risk tumours, and a much smaller benefit for high risk tumours. PROTECT-T is the most modern trial. That was a UK trial. It was published in 2016. That didn't show any difference at all in prostate cancer mortality and overall mortality between active surveillance, radical prostatectomy, and radical radiotherapy in those patients with low risk and intermediate risk tumours. It did, however, show that radical prostatectomy and radical radiotherapy does reduce disease progression, and disease progression was defined as progression to locally advanced tumours, local metastases, a need for hormones, developing malignant rectal fistulae, and a need for catheterization. What other outcome differences were they? Well, they're all, to me, very, very minimal. I put them down just to, because this was published in the part of the PROTECT-T. Radical prostatectomy and radical radiotherapy does reduce the rate of development of distant metastases in comparison with active surveillance in men with low and intermediate risk tumours, 3% versus 3% versus 8% at 10 years. Again, this looks further and all these differences get smaller. There's some advantage of preservation of urinary continence with active surveillance and radiotherapy over radical prostatectomy. There is limited evidence that sexual function is better preserved with active surveillance and to a lesser degree radiotherapy. And I'd just like to point this out to you because this will tell you something about science and how science is evaluated. If you look at this, you actually do better with radiotherapy with your erections than if you have active surveillance This is clearly nonsense. This would mean that you would have to irradiate men to improve their erections. And clearly what this is an intention to treat analysis, and some of these patients have crossed over to a different group. So you have to be always very wary of how you interpret data. And there is some evidence that bowel function is better preserved with surgery or radiotherapy, surgery or observation over radiotherapy, but these are such minimal differences that I don't think they matter clinically. Okay, that was the end of this session.